I would like to invite Staci Bush from Gilead to come and join us. Staci is the Global PrEP Medical Lead for Gilead Sciences. The floor is yours. That goes forwards. That goes backwards. Let's go back there. Very good. Okay. Thank you.
So I'm here to talk a little bit, probably less scientific than my colleague from France, but he set me up perfectly to talk about some of the challenges of getting women not only into PrEP and implementing PrEP, but also getting women, specifically Black women, into clinical trials. I do a lot of work in both the US, of course, but also in South Africa. But I wanted to use the US women as a case study because some of the barriers to PrEP implementation have been removed. So you're in a country where PrEP is approved, where PrEP should ideally can be free. We find that less than 2% of people have a cost barrier to receiving the medication. And we still see very low implementation in women. I'm gonna go through these slides pretty quickly because this is not new to you. But what I want you to think about is how this translates to other populations, and as we get to the end of my very short talk, how this affected how we can get women into clinical trials for new deliveries of PrEP. So in the US, we see that women make up 20% of the new HIV infections. So women living with HIV is a strong population in the US, but it's overwhelmingly a male epidemic, very different than when we look at sub-Saharan Africa. But we also see that it's not the same across races. In the US, similar to sub-Saharan Africa, it is very much a heterosexual transmission disease, but not solely. We see that in certain populations, it's more of an IVDU. And we know there's different stigmas that come with PWIDs. It's also not just a racial issue or a transmission issue. In the US, it's very specific to a certain population. It's geographically specific. We've seen maps like this at different conferences where you can see that the concentration, let me see if I can have is in the South in women. Well, but what you really don't see is that really is specific in certain cities, very large urban areas in the South in New York. So if I look at, this week I was in Georgia, Atlanta. You may have heard of Atlanta, Georgia. The epidemic is really a zip code disease. So when we get to this 20% where that population is ignored, and then we get to the racial differences, and then we get to the transmission differences with MSM, and then when we get to the geography differences, and it has to be pinpointed to a specific city. The need for the HIV epidemic is really diluted in women, especially Black women. In our country, the South is specifically a higher majority African American. And when I look into implementation, we never talk about this. We always talk about young MSM. But the epidemic in women are these young but older, I'm in the 45 plus, women. So where do we, when we're talking about adolescents, young, where does the message get lost when we talk about age with women? These are usually women who haven't used condoms since they're outside of their pregnancy age, they're divorced, and their risk of number of partners is very low. So PrEP implementation. This starts at 2014, but we know that Truvada for PrEP was approved in the US in 2012, but we haven't seen a growth in the percentages of women using PrEP. The numbers have grown slightly, but the percentages have remained slow, especially when you compare it to the HIV epidemic. And then when we look at PrEP utilization by race, this is a lot of where I focus a lot of my research when I have time. PrEP implementation in the United States, even though the epidemic is racially, over half of new infections are in African Americans, and again, this is class, race, poverty level, urban settings. PrEP utilization, because of our insurance systems and many other things in the US, just looking at this as a case study, PrEP utilization is mostly in whites. My colleague already went into detail about the risk factors for women, about the difference in seroconversion rates in women just with vaginal sex versus anal sex. We can look at cellular levels, how many cells are in place, but also how long semen stays in a system. We all know that receptive partners are more likely to acquire HIV, and when you look at a woman and how it's biologically how we're made, it's just like a cup. And semen is sitting there for 3 days, where the cells are really likely to pick up HIV infection. We also know I've talked about a lot of differences, but similarities with this young MSM population we talk about so much, that a surrogate HIV infection could be STIs. Women have certain systems. They go to OBGYNs, they go to different contraceptive clinics and get their STIs tested. This is very different than most of the clinics I worked in, where we focus on HIV and male health. And when I talk to these OBGYN providers, they have no idea about PrEP. And they have no idea about HIV testing. So again, another difference when we talk about the population we usually focus on. We also don't understand, I talked about age, but we don't understand when women are at their highest risk. The irony is, once a woman is pregnant, they're almost more likely to acquire HIV. There's no reason in many women's minds to use a condom once you're already pregnant. Also, the biology of a woman when she's pregnant and the cellular thinning of her cervix and her vaginal tissue make her more susceptible to HIV virus. I like these two graphs because they show two things. One, if you look at HIV incidence, you see during late pregnancy, it's high, but per act is highest postpartum. What I think this says is that women don't like to have a lot of sex right after they have a baby, but that's when they're most susceptible. And then when we look at considerations, we're getting to the idea of looking at PrEP trials. We have to also look at the idea of what does this mean for the baby? What does this mean for the pregnant woman? What does this mean for breastfeeding? And we see a lot of safety there, but again, these are continued studies and simultaneous studies that put an extra burden on PrEP studies. So barriers to PrEP, multifactorial. There's behavioral issues, there's biological issues, there's epidemiological issues. But women, we've seen this kind of chart before, with women have, again, multiple barriers to implementing any health care for themselves. And when we measure that against all the many demands on cisgender women especially, we see that PrEP and prevention become very low on their list. We also have seen that because of these barriers, lack of knowledge about PrEP, family, friends not supportive of PrEP, the correlate to using PrEP is if you have the support. We saw this in Partners PrEP, where if their partner is someone living with HIV, they were more likely to stay on PrEP, implement PrEP. We also see this in the trials that people will take PrEP, walk out of the clinic, and say that their family or their partner talked them out of continuing PrEP. Again, I think this is a difference when in the MSM community, in the US especially, people are supporting each other taking PrEP. And this, again, is very US-centric, but our guidelines did not, until recently, provide a space for women to fit in the criteria for PrEP. If our CDC guidelines gave both recommendations and summaries, and until recently, you had to have multiple partners, you had to have evidence of STIs before you were allowed or indicated for PrEP. Now we know that women and men can self-identify as a person for PrEP. I had patients who came and said, I haven't had sex in years. I want to get on PrEP so I can have sex. But our guidelines didn't allow that, and our recommendations from the CDC. And this just kind of says more of the same. If you were using a criteria to indicate you were eligible for PrEP, there was no room for women in these indications. And self-perception of risk. This was done in the US. Kim Smith did similar, one of my friends knows, one of the providers, Kim Smith, did this same experiment in her clinic. When you ask a man, do you think you're at risk? You're in an STI clinic. Do you think you're at risk for HIV? About half said yes. The tester, 3/4 of them said, yeah, that person's at risk. But when you look at women, not even 10% of women in an STI clinic thought they were at risk for HIV. And you see 60% of the providers said the same risk you have to bring you to this STI clinic is the same risk you have for HIV. So women don't know. They don't know they're at risk, and they definitely don't know about PrEP. If you look on the left-hand side, how many women had heard of PrEP? 10%. Once they've heard about PrEP, 2/3 said, yes, I would be a candidate for PrEP. I would take PrEP. So all this comes into play. This is the important part. This is what I came to talk about, is why it's difficult to get women into PrEP trials, but you can't get there in a silo. We have to have the discussion about women aren't using PrEP now in a country where it's readily available. So recently, I'm here from Gilead Sciences. We met with the FDA, and we talked about how we can do a PrEP trial. The first thing is that the old Truvada for PrEP trials, if we remember, they were all placebo-based. Now, we know that's unethical now. We wouldn't have a placebo trial when we have a drug that works for PrEP. So then the question is, how can we find a non-inferiority number to measure a new drug against? I think my colleagues from other companies will talk about this similar challenge, but how do we get this number for women? For men, it was easy. We used the IPREX trial, we used IPREGAY, we used PROUD. We were able to use all these Truvada for PrEP trials that showed efficacy for PrEP and measure a new drug against that number. But for women, it was more challenging. So my colleague from France discussed all these trials in a little bit more detail, but what you see is that what pulls the number down, and you can't find a non-inferiority model, is because there were numerous trials in women, especially FemPrep and Voice, where the women did not take the drug, and there was no efficacy. I go back to Partners PrEP. Partners PrEP was effective, but at the time, we didn't have treatment as prevention. Women walked in, they said, my partner is not on medication. They weren't indicated for medication at this time. You have to think this was probably about over 10 years ago. So my partner, in these countries, my partner had to reach a certain CD4 before medication was started. So I have a partner who is living with HIV, untreated, so I want to take PrEP. And I am probably going to be adherent. Even if I don't know if it works, I'm going to be adherent because I know I'm at risk. So again, Truvada trials were at a different time. We didn't have treatment as prevention. We didn't have test and treat. And the most likely reasons a woman would take PrEP is because their partner was infected. When we look at just active single women, they didn't take PrEP. There was no efficacy, and we cannot come up with a number, let's say, to compare to show efficacy in a new drug. Now, even if we could find this number, and this is just another way to illustrate it, the FDA even admitted determining a non-inferiority model is difficult, if not impossible. Other newer drugs, and people will talk about this later, they had to shoot for superiority. And it's really hard to do that if you're looking for another pill. But even if we could find a non-inferior margin, these trials would be so large because the risk of women is so small and scattered. So while we had the Discover trial, 5,000 MSM and transgendered women. For a trial similar for women at the time would have been exponentially larger, probably 500,000 women. In the US, we currently have about 220,000 people on PrEP, mostly men. But we would have to look for 500,000 women. And this would take, even if it was possible, it would take probably a decade before a new drug would come to market. So very large trials, very long trials, and this was even if we could find a non-inferior margin. And this is where we are now. Women just aren't using PrEP. So finding this large number seemed near impossible. Recently, the FDA has come back and they said, we've seen this challenge and we're opening up new innovative models to study PrEP in women. We'll do new mathematical calculations. If you find the right population, usually in sub-Saharan Africa, we will allow this. But up till recently as July 2019, trials in women were, they said themselves, really impossible. So what I hope we talk about when we have our panel is what are the next steps? What are the next things we can do? Because I firmly believe that PrEP is needed in a female population, especially women who look like me. But until recently, it's been a continued challenge. Thank you.